previously we were talking about the technique in your cardiac examination, and this includes your inspection, palpation, and percussion. So now you're ready to perform the auscultation. Okay. So you still remember this one, the 5-finger approach for cardiovascular examination. So we're now on the 5th, so auscultation. So auscultation was first described by Hippocrates, Boyle, and Double and Hook. Direct auscultation could be direct auscultation or indirect auscultation using a device or an instrument. So this is your direct auscultation. So you this is actually not often utilized because of concerns of modesty and hygiene. So you directly listen to the chest of the patient or the person you are examining. So this is Laennec. So he is the inventor of the stethoscope. So this is the first stethoscope that was invented by Laennec. So isa lang yung head. And this is where this portion is put on the chest of the patient, and then the other end, you put it on the ear of the examiner. So ito na yung bago, the 3-head or the two-piece or head chest piece. So this is the stethoscope that was used by Laennec initially. So diba? So indirectly, you can listen to the chest by this instrument. This is now your stethoscope. So this is the original replica of the Laennec's stethoscope. But then Harvey had also invented the triple head stethoscope. So ito yung triple head, 1, 2, 3. So this is the third. So this one, and this one. Huh? That's the triple head stethoscope, which was made by Harvey. So that's the triple head. So let's first know the different parts of the stethoscope. So the parts of the stethoscope work together to allow the user to hear the internal sounds of the patient's body. So these sounds are transferred from the stethoscope to the medical professional's ear to enable proper diagnosis of a patient's condition or illness. So one part of the stethoscope is your chest piece. This is also known as the head, which is the part of the stethoscope responsible for conducting sound. This is also the part that is placed against the patient's skin. So there are some stethoscope that is one-sided, or there are some chest piece that are two-sided, depending on the model. So the one-sided usually are the mga what's this? The cardiac stethoscope, where the chest piece has only one side, but it works as both the diaphragm and the bell of the stethoscope. The only difference is that the center of the chest piece or the head may hole siya, which is just like the size ng imo needle prick. And when you press the chest piece or apply pressure over the chest piece into the chest or the chest of the patient, it serves as a bell because you can now hear soft sounds or low-pitched sound. So one-sided chest pieces only have diaphragms. I've said diaphragm lang siya, but then it can work both ways. So as diaphragm and bell. So there are also some device or stethoscope that have tunable or pressure-sensitive diaphragms that can act as both a bell and a diaphragm. Ito na yung sinasabi ko. When you put pressure, it will now act as a bell. The two-sided chest pieces have a diaphragm on one side and a bell when flipped over or rotated. So chest pieces are usually made of metal, but there are now also mga acrylic head stethoscopes which are great for blocking out ambient noise. So the chest piece is made up of the diaphragm and or bell and the stem. So later I will show you the different parts. So the diaphragm, this is the circular end of the chest piece. On two-sided chest pieces, the diaphragm is the larger of the two ends. Its larger size allows the user to listen to a bigger area of the patient's body. The diaphragm is designed to pick up sounds with higher frequencies compared to the bell. So the stem is the part that connects the chest piece to the stethoscope tubing. So it is usually made of metal or steel. On stethoscopes with two-sided chest pieces, it also is the part that allows the user to choose between the diaphragm and the bell. So this is done by simply rotating the chest piece, then clicking it into place with a ball bearing. So rotating the chest piece will determine whether the diaphragm or bell directs sound to the ear tubes. The tubing is responsible for transferring and relaying the frequencies or sounds picked up by the chest piece. So it directs the sounds to the ear tube so that the user can hear them. So stethoscopes often come with either a single tube or a dual tube design. So with dual lumen tubing, the tubing is actually split in half on the inside. So hasulod ito ya. So there are two, kumbaga there are two lumen inside. So the tubing is actually split in half on the inside, creating two sound channels inside and outer, inside one outer tube. So this creates a left and right path so that the sounds can reach the user's ears with greatest accuracy. So the headset is that half of the stethoscope often seen hanging from a healthcare professional's neck. So the headset is composed of two ear tubes, tension springs, and ear tips. So the ear tubes connect the stethoscope tubing to the ear tips. So this is made of metal or steel, and they are designed to be at the optimal angle for the best fit into the user's ear canals. The ear tubes isolate and direct the sounds into the left and right path to provide the user a clearer and a more accurate listening experience. So they have ribbed ends where the tips are then placed. So the ear tips are the parts that actually go into the ear. It is made up of rubber or silicone and have a hole in the middle for letting out sound. So the ear tips are placed on the ends of the ear tubes to provide an acoustic seal as well as to improve user safety. The ear tips should provide a snug but comfortable fit for the user. So they often come in different sizes to accommodate different ears. So this is now your stethoscope. So this is your chest piece, ito. So this is the bell. So the other portion which is larger is the diaphragm. So it's the tunable diaphragm. And this one, itong metal that connects to your tubing is your stem. So this one, the black one, is your, so this one, the black one is your tubing. So this one is your ear tube. Tapos this one is the ear tip. So the whole set here is your so-called headset. Huh? So that's your headset. So what's an ideal stethoscope? So it has a large ear tips as much as possible to accommodate lang yung ear liwat. So it should have an adjustable headpieces, a vinyl tubing, which is not more than 25 cm, hindi masyadong mahaba. The internal diameter of the tubing should be 3/16 internal diameter, with shallow, large diameter bell and a smooth, stiff, thin diaphragm. So we're now ready to auscultate. So you now know the different parts of your stethoscope. So we're now ready to auscultate. But before we auscultate, we should know the different parts or the clinical valve areas for auscultation. So these are actually the area that corresponds to the different valves. So this one is your aortic valve. This is the area for your aortic valve kasi diba dito, ito yung aortic valve mo. And the radiation of the sound can be radiated into the second intercostal space. And ito, right external border. And then this is your pulmonic area. It is opposite your aortic, also on the second intercostal space, left parasternal border. And then you have your mitral. So your mitral, the sound created by the mitral valve is projected into the apex. Kaya you can hear the sound or the apex bit here at the, so this is the apex, the tip of your heart or the left ventricle, which is located at the 5th ICS along mid-clavicular or left mid-clavicular. And then you have your tricuspid. So your tricuspid is actually at the 4th ICS. You can hear that at 4th ICS along left parasternal border. So those are the clinical valve areas for auscultation. So what do you think is wrong with this painting? So what is wrong with the painting? Ikaw, Judian. Pilipinosas. What is wrong with the painting? Anything wrong? Kitala. Christopher Ubejas.
Position of the patient.
The position of the patient. Sige. Ikaw, Noel. What's wrong with the painting?
Privacy, Doc.
Ha?
Privacy.
Privacy. Ikaw, Koan, Geraldine.
The position of the chest piece, Doc?
Position of the chest piece. Carmelita, Chu.
The length po of the headpiece, I think, is too long.
Length of the headpiece.
Length of the tubing po, Doc.
Tubing.
Is too short, Doc, I think.
Kevin.
The position should be in upright. The patient should be in upright position.
Upright. Ara.
And doctor po is too close to the patient.
The doctor is too close. Judel.
Feeling ko, Dok, damot tao, tapos maringasa dito, Dok. Subangin, kailangan na daha close space para mabatanin na auto.
Damot tao. Sinya.
And position po, Doc, and doctor, dapat ay my right.
So, position of the doctor. Sige, okay. So, where should be the position of the, of the doctor?
Right side, Doc.
Right side. So, pero, depends, gihapon, Kasi there are some, doctors who are right-handed or left-handed where they are comfortable. Although itong correct position should be at the right side of the patient. Pero depende hapon. So position does not matter. Pero one have mentioned regarding the privacy. So if you look at the damo itong damoan mga, di ba damo tawo inside. So it can also pwede maka-distract from the physician. Kasi he's now trying to auscultate. Another is the position of the patient. Tama naman ang position ng pasyente. One is did the doctor expose the area that where he should auscultate? Hindi masyado siyang in-expose yung area. So you should expose the area that you should auscultate, Tapos regarding the length, since this is pedia, parang pediatric ang pasyente, usually pediatric stethoscope are shorter than the adult ng mga stethoscope. Although kanina it was mentioned regarding the length na 25 lang 25 cms. Pero pediatric usually have shorter length of the tubing. Their tubings are usually shorter. Even cardiac stethoscope are usually shorter. Tapos what else? Ano pa ba? Ano pa niyo mention kanina? Wala na ada. Sige. Okay. Let's continue. So, this one, what's wrong?
Waray po, Dok.
Expose an area nag-auscultate.
Ano?
Waray niya gin-expose an area nag-auscultate.
Oo. So, you should not put your chest piece on the top of the clothing hanimo patient, because you cannot hear clearly. Sometimes may mga interferences caused by the rubbing of the chest piece into the clothing of the patient. So it's wrong to do this, Hindi yan tama. So this is how not to examine the heart. So hindi yan tama, ha? Sometimes you will see some doctors who are doing it. Also, sometimes ako, if nagmamadali, I'm doing that. Especially now that it's pandemic, because we want to do away with cross-infection. Diba? Kasi from the chest, tapos ikakatong another chest and pasyente directly. There are some mga secretions, sweats, like that may infect other patients also. So sometimes we even put mga covers on ang chest piece to protect cross-infection. But it's not the proper way, huh? It's not the proper way to auscultate. Putting your chest tube or covering your chest tube, your chest piece, or covering your chest piece with barriers. Kasi it will affect your auscultatory finding. So, do you still remember your cardiac cycle? So what are the phases of your cardiac cycle? So you have your systole and your diastole. So systole this is actually your active contraction of your heart, of the heart, while diastole is the relaxation ng imong heart. So during relaxation or diastole, what valves are open? So it's usually your atrioventricular valves or your tricuspid and your mitral valve. So that's during diastole. So during systole, where blood is being injected into the systemic circulation and to the pulmonary circulation, what valves are open? So it is your semilunar valves or your aortic and pulmonic valve should be open. This one should be closed. Your atrioventricular valve should be closed. Pag diastole, unclosed naman, these two. During systole, these two are closed and these two valves are open. Okay? So this is your Wigger's diagram, and it actually summarizes what happens to your the cardiac cycle, what happens to your the different pressures and volumes inside the heart. So during atrial systole, your valve is closed, diba? Close pa ito ya. But at the end of your during atrial systole, your mitral valve is open kasi nag-diastole liwat ito ya. It is filling your left ventricle with blood coming from the left atrium. So at the end of your atrial systole, your mitral valve closes, diba? So your mitral valve closes, kumbaga puno na ni mo left ventricle. So and it starts your isovolumetric contraction until the pressure inside your left ventricle increases or exceeds the pressure in the aorta. So that's why your aortic valve opens and it will start now your ejection or rapid ejection phase. So if you look at the during the isovolumetric contraction, so the volume of blood in the left ventricle, diba, nakakuha nito at its peak, naka-plateau ito. But during rapid ejection, you have rapid decline naman of your left ventricular volume because your blood is ejected into the circulation, to the systemic circulation. So until you have reduced ejection. Tapos the pressure in the aorta exceeds now the pressure of the left ventricle, so that this now causes the closure of your aortic valve. So with closure of your aortic valve, this now starts your isovolumetric relaxation. So you will have rapid ventricular filling. So if you look at the ventricular volume, mas start na liot hiya pag rise and imo volume in the left ventricle, and the cycle repeats. Okay, naintindihan niyo. Very simple like to hiya. Your cardiac cycle showing the left atrial LV pressure and your aortic pressure correlated with the flow on the aorta to your ventricular volume and your heart sound. So, and heart sounds naman, what creates the first heart sound? If you still remember your physiology, kita adidi in your Wigger's diagram. Din hiya naka-time it imo S1 and your S2.
Mitral valve
Mitral valve what?
closes.
So closure of your mitral valve. So at the same time, ano mo tricuspid valve ito kasi kuan. Pero usually gimpapakita lang ito in the Wigger's diagram is your mitral valve. And your S2 is timed with what? Hain ito ya. So diastole, during diastole, di ba S2, that is the closure of your aortic valve. Closure of your aortic valve. So simula, maintindihan mo if you know the cardiac cycle. So that's Dr. Wigger, and he's the one who developed this Wigger's diagram. So there are two phases, your systole and your diastole. So your systole is you have active contraction of the ventricle. So diastole, relaxation. So what are the pressures inside? So we have normal pressures and flow rates in the cardiovascular system. So the pressure in the systemic arteries is about 5 to 6 times greater than the pulmonary artery. And your LV output is slightly greater than your right ventricular output. So your cardiac index in a normal recumbent adult is actually 3.4 liters per minute per meter squared, and the stroke volume is approximately 47 ml per beat. So these are different pressures inside. So in a normal recumbent adult, the normal, this is your left atrial pressure is 6 to 20 millimeters mercury. In the left ventricle, you have 90 to 140. Right atrium 2 to 14. Then 15 to 28 in the right ventricle. So you have your pulmonary artery pressure, which is 15 to 28. So during diastole, an imo right ventricular volume and LV volume have different volumes, 0 to 8 and 4 to 12. So let's now do the different heart sounds. So this is your, if we draw a diagram of your heart sound, this is your first and your second heart sound. So your first heart sound is created by the, as mentioned kanina, closure of your, what is M? Mitral and your tricuspid valve. And your S2 is created by Uri man yun na baton.
Aortic and
Shore of
pulmonic.
aortic valve.
Closure your aortic and your pulmonic valve. Kaya, di ba dalawa? So this is during expiration. So during expiration, you will hear only one sound. So S1 and your S2. However, during inspiration, you have a splitting of the second heart sound. Dito rin ang kakadungan. Nira pag close during inspiration. So you have a splitting. Kaya you will see here that the sound is split. Pero hindi siya masyadong malayo. That's a normal splitting during inspiration that occurs during inspiration. Okay. So the first heart sound is produced by vibrations generated by closure of the mitral and tricuspid valve. So it corresponds to your end of, of diastole and beginning of your ventricular systole. And this will precedes this precedes the upstroke of your carotid pulsation. So M1 is best heard over the apex of the heart, and T1 is best heard over the fourth ICS at the left sternal border. So that's the auscultatory area of the tricuspid valve, diba kanina? So S1 is a high-pitched sound that is best heard with the diaphragm of the stethoscope. And the intensity of S1 depends on the integrity and pliability of valvular cusps and the length of the PR interval. Now, the strength of the ventricular contraction, the presence or absence of valvular stenosis or regurgitation, and the position of the valve leaflets at the end, and the tissue between the heart and the stethoscope also is responsible for the intensity of your S1. So what are the conditions associated with a loud S1? So this includes an increased transvalvular gradient, like when you have mitral stenosis, tricuspid stenosis, or atrial myxoma. When there is an increased force of ventricular contraction, like in tachycardic patients or during or in hyperdynamic such as anemia, thyrotoxicosis, or when you are exercising or when you are given inotropic agents. Shortened PR interval also can cause a loud S1, and this is in patients who have WPW or in tachycardia or pre-excitation syndromes, and in patients who have mitral valve prolapse or in thin individual persons. So your S1 could be diminished in intensity when you have an inappropriate apposition of the valves. So when we say inappropriate apposition of the valves, has mitral regurgitation, tricuspid regurgitation, or in dilated cardiomyopathy because you don't, there's no more coaptation of the valves because the annular ring is already dilated, kaya hindi na nagko-coaptate. Prolonged PR interval also can diminish the intensity of your heart sound, S1. These are seen in patients with bradycardia, those with heart blocks, or in digitalis toxicity. When you have decreased force of ventricular contraction, as in patients with cardiomyopathy, myocarditis, myxedema, and myocardial infarction, or in an increased calcifications of the aortic valve, or your AV valve, in mitral stenosis or post-irradiation. This can lead to calcifications of your atrioventricular valve. Increased distance from the heart. So kung obese or those with emphysematous lung or pleural effusion or pericardial effusion, this can diminish the intensity of your first heart sound. So splitting of the effect of the first heart sound. So normally, the mitral valve closes just prior to the tricuspid valve. So your M1 is audible before your T1. But the difference is not detectable. That's why you will only hear one sound, an MS1. Splitting of S1 is more prominent when the time difference between the closure of the mitral and the tricuspid valve is increased. So this can happen with early closure of the mitral valve or a delayed closure of the tricuspid valve relative to the valve. So these are some of the conditions that may cause a splitting of your first heart sound. So in premature ventricular contractions of the LV origin, so right bundle branch block, because what is activated first when you have right bundle branch block is your left ventricle, tapos delayed and right bundle. Right bundle, right ventricle because of the block in the right bundle. And when you have LV pacing, meaning to say LV pacing, the LV lead, the lead is put in the left ventricle. So pacing lead yan. Pacing lead is placed on the left ventricle. Or when there is Epstein anomaly or in atrial septal defect. In severe stenosis, the tricuspid valve closes after the mitral valve. So this difference can be perceived on auscultation. So you will see a reverse splitting of the first heart sound. And this occurs when your M1 follows the closure of T1. So T1 anay na una, then M1. So this happens when the closure of mitral valve is delayed. And this can be seen in patients with left bundle branch block. So what is activated first is the right ventricle, because there is a block in the left bundle. So now orihan imo left ventricle. So what is activated first is the right ventricle. Or if you have RV ventricular or right ventricular pacing, so the pacing lead is placed on the right ventricle. So opposite kanina, di ba? The pacing lead is placed on the left ventricle. In severe mitral stenosis and in patients with left atrial myxoma. So this is the normal heart sound, first heart sound. So in a normal individual, so at the base, the first heart sound is softer than the second heart sound. So base nga ni didit maimo aortic area, second interspace. So natural loud. You will hear louder. So kaya mas mahaba siya. This one, soft. At the apex naman, your S1 is louder than S2 at the apex. So S2 is characteristically louder than S1 at the base, and S1 is usually more prominent than S2 at the apex, but this relationship is less constant and less reliable for timing purposes. So you can have splitting of the first heart sound. At times, one may hear splitting of the first heart sound into the loud early mitral component and a softer tricuspid component. So this splitting is best heard at the lower left sternal border or at the xiphoid area. Okay. So the tricuspid component here radiates poorly. So at the base, you have, so this is the base. So you have a louder second heart sound than the first heart sound. And S2 would split during inspiration. So at the apex, your S1 is louder than S2. So when you listen, you should listen at the base as well as the apex. Kanimo heart sound. So what are the factors that will affect the first and second heart sound? So your valvular, atrial, muscular, and vascular components can be demonstrated by special recording techniques. And these are the factors that will affect the intensity of your S1. So position of the atrioventricular valves at the onset of systole. Structure and mobility also of the leaflets can affect the first heart sound. The rate of pressure rise and tension development in the ventricle. So this actually reflects the status of the ventricular contractility. So fourth is transmission characteristic of the chest wall and the thoracic cavity. Like for example, kung obese, if the patient has emphysema, this can affect the transmission of your of the sound. And physical characteristics of the vibrating structures. So what are the causes of a loud S1? So a loud first heart sound is heard in the presence of a short PR interval, mitral stenosis, exercise, tachycardia, anemia, hyperthyroidism, and hyperkinetic states. A faint S1 usually occurs in the presence of a long PR interval, and it frequently occurs in severe hypertension. So, loud S1. So you can hear this in mitral stenosis, hyperdynamic state, or pre-excitation, or AF with short cycle length. You can also hear naman a soft S1 when you have long PR interval in severe hypertension, mitral regurgitation, aortic regurgitation, myocardial infarction, shock, mixed edema, and left bundle branch clot. So you can also have varying intensity of your S1. So this can be heard in patients with atrial fibrillation, those with complete heart block, Wenckebach phenomenon, and pulsus alternans. So what about the second heart sound? So the second heart sound is produced by the closure of the aortic and the pulmonic valves at the end of systole. So your A2 is best heard at the aortic area. P2 is best heard at the pulmonary area. S2 is a high-pitched sound heard best with the diaphragm of the stethoscope. And the intensity depends on valvular factors, the transvalvular gradient, the mechanical factors, and the size of the great vessels. So the intensity of your A2 is increased when there is systemic hypertension, in coarctation of the aorta, aortic aneurysm, in thin individuals, and when the aorta is closer to the anterior chest wall, as when it may occur in patients who have tetralogy of Fallot and transposition of great arteries. Now, the intensity of A2 is decreased with decreased aortic diastolic pressure, as in aortic regurgitation, those with improper valvular apposition, like when you have aortic regurgitation or aortic dissection, calcific immobile valves, as may occur with calcific aortic stenosis, and decreased systemic arterial pressure. Now, the intensity of pulmonic component, or your P2, is increased with pulmonary arterial hypertension from any etiology. So a loud P2 is also audible with ASD, although the mechanism in this condition is unclear. Splitting of S2. So normally the aortic valves close slightly before the pulmonary valve. So you have a normal splitting. Split talaga sila. Oo. So the difference is more pronounced when you have during inspiration due to the increase in your right ventricular stroke volume. The splitting of your second heart sound results from aortic valve closing slightly before the pulmonary valve. This is more prominent with inspiration. So pulmonary and aortic valves remain briefly after the end of the systole and after left ventricle and RV pressures have been lowered compared to your aortic pressures, if you still remember the Wigger's diagram or your cardiac cycle. So this interval between the actual valve closure and pressure crossover between ventricles and great vessels have been called the hangout time, which is inversely proportional to the resistance to blood flow in the great vessels. So the pulmonary vascular resistance is less than the systemic vascular resistance. So hangout time is longer for the pulmonic valve than for the aortic valve. And this accounts for the delayed closure of your pulmonary valve relative to the aortic valve. So during inspiration, pulmonary arterial resistance will further decline, leading to a delay in the pulmonary valve closure and a more pronounced splitting. So another factor contributing to delayed closure of pulmonary valve with inspiration is prolonged RV emptying due to increased stroke volume as a result of an increased preload with inspiration. So the splitting of your S2 is an interplay of your dynamic changes in the pulmonary vascular impedance and changes in the systemic and pulmonary venous return. So you will have prolongation of RV ejection, or you can have a decrease in your LV ejection, causing a widening of the splitting interval during inspiratory phase. So on inspiration, this disparity in ejection time is minimized. So your A2 and P2 interval is separated by less than 30 milliseconds. So your S2 is narrower or heard as a single sound. And this is best heard at the pulmonic area. So normally with expiration, S2 is single. As the aortic and the pulmonic valve closures occur almost simultaneously. So if at expiration, the two different components of your S2 can still be appreciated separately, then you have a widely split S2. So the wide split can result from delayed closure of the pulmonary valve or early closure of the aortic valve during expiration. So the delayed closure of pulmonary valve can result from conditions or hemodynamic abnormalities. And the delayed electrical activation of the right ventricle accounts for the delayed onset of systole, with delayed completion of right ventricular emptying. So you have a delayed closure also of the pulmonary valve. So this can happen with right bundle branch block, LV pacing, PVCs arising from the left ventricle, and WPW with pre-excitation of the left ventricle. So the hemodynamic reasons for delayed closure of the pulmonary valve or pulmonic valve include right ventricular outflow tract obstruction, pulmonary hypertension, and pulmonary artery branch stenosis. The closure of your aortic valve occurs with early emptying of the left ventricle. So this is seen in mitral regurgitation, in ventricular septal defect with left to right shunting. A widening of the splitting of your second heart sound may also occur with respiratory variability. And this is seen during inspiration. So the split becomes wider and compared to that during expiration. So a wide splitting or a wide or fixed splitting of your second heart sound may occur. This is seen when the respiratory variability in relation to your A2 and P2 is lost. And the time interval between your A2 and P2 remains relatively constant, with P2 following A2. So fixed here. So this occurs most commonly in ASD with left-to-right shunting, but it can also occur with right ventricular failure. Now, the exact mechanism of the fixed split in ASD is unknown, but there are some postulates that the right ventricular systolic time remains relatively constant. So in the presence of ASD with left-to-right shunt, the RV stroke volume is composed of contributions from the superior vena cava and the left atrium. So during inspiration, the contribution from the superior vena cava is increased owing to the increased blood flow from the body to the heart. So during expiration, there is a greater flow across the atrial shunt. So the net RV stroke volume remains constant throughout the respiratory cycle. So what are the conditions associated with RV failure? So, or conditions associated with RV failure that can cause fixed splitting of your S2. So these are your primary right ventricular failure, pulmonary hypertension, and RV outflow tract obstruction. So reverse splitting can also happen. Here, A2 is audible after P2 during expiration, and S2 is said to be paradoxically split, or you call that as reverse splitting. So this can also happen when your right ventricle contraction is completed before LV contraction. So nauna, mo right ventricle. So this can result from conduction or hemodynamic reasons. So the reverse splitting due to conductive disturbance occurs in conditions that cause delayed activation of the left ventricle, such as left bundle branch block, RV pacing, PVCs of RV origin, and pre-excitation of the right ventricle in WPW syndrome. A reverse splitting due to hemodynamic reasons occur when you have delayed emptying of the left ventricle, as what is seen in left ventricular outflow tract obstruction caused by aortic stenosis. So you have reverse splitting. So naunaan and P2 is louder than your A2. So you can also hear some diastolic feeling sounds. So these are your S4 and your S3. So an atrial sound that occurs in pre-systolic patients with hypertension or coronary artery disease and long intervals. A feeling sound may occur early diastole in children as well as in young adults, but it disappears with age. So this sound is called as a normal third heart sound. So in middle-aged individual, it is also called as ventricular galloop, and it indicates myocardial failure or AV valve incompetence. So atrial sound is your S4, huh? Atrial sound occurs pre-systole. So if you look at this one, so S1, S2. So itong period is systole. So after S2 is diastole. So your S4 occurs pre-systole, before systole. Before systole. So you have here. While your third heart sound naman, so early diastole in children. Early diastole. The third heart sound, ito pala. Early diastole. Kasi diastole in a period between S2 and S1. So early diastole. So you also have early diastolic sound or your pericardial knock and your quadruple rhythm. So in constrictive pericarditis, you can hear a sound that occurs in early diastole. So early diastole. And this is called as your pericardial knock. So it is early, louder, high pitch than the usual ventricular galloop. So this is actually an accelerated form of feeling sound. Kasi during diastole, di ba, feeling ito, ventricular feeling. Now, if both atrial and ventricular gallop are present, it is called as quadruple rhythm. So this one is pre-systole. So it is called as your atrial gallop. This one is ventricular gallop. So if you have this ventricular and atrial gallop, so what? And then you have your second heart sound and your first heart sound. This is now called as your quadruple rhythm. So you can also have incomplete summation gallop or your summation gallop. So at faster rates, these sounds occurring in rapid succession may give an illusion of a mid-diastolic rumble. So para siyang mid-diastolic rumble. Kaya it occurs after your second heart sound. So when the heart is sufficiently fast, so very rapid na siya, the two rapid phases of your ventricular force reinforce each other. So magiging isa na lang, a loud. So it becomes a loud summation gallop that may appear. And this sound may be louder than the other two heart sounds. So louder than S2, louder than S1. Mas maano siya. So that's your summation gallop. So you can also have some early systolic ejection clicks. So ejection clicks, pwede siyang, the origin from the aorta. So you have your aortic ejection sounds that is heard at the apex and base. Usually they have little respiratory variations. Your aortic ejection sounds are seen in coarctation of the aorta, aneurysm, dilatation of the aorta, hypertension, aortic stenosis, and aortic regurgitation. Your pulmonic ejection sounds, on the other hand, radiate poorly, and it is usually heard at the base only. So it will be diminished or disappear with inspiration. So pulmonic ejection sounds occur in valvular pulmonic stenosis and in idiopathic dilatation of the pulmonary artery, as well as in pulmonary hypertension from any cause. So heart murmurs. So heart murmurs are of longer duration than heart sounds. So they originate within the heart itself or in its great vessels, and they are usually caused by one of the following mechanisms. So this could be due to a flow across a partial obstruction as seen in stenotic valve. So it creates here a turbulence, so you will hear a murmur. Or it could be due to a flow across a valvular or intravascular irregularity without an obstruction. So wala siyang obstruction pero there is irregularity. So that's why it also creates some sort of turbulence kasi dapat lamellar lang yung flow. Because there are irregularities, it creates some turbulence in this. So it creates a sound, an abnormal sound, a murmur. So third is an increased flow through a normal structure. Pwede siyang normal yung structure, but because of the increased flow, makusog, turbulent, itiya flow. So it also creates a sound, an abnormal sound. Or there is a flow in a dilated chamber. So the currents here becomes edgy kasi dilated and emo chamber. So it also creates an abnormal sound. So another is a backward and regurgitant flow across an incompetent valve. So supposedly it should be closed, the valve should be closed, but since it is incompetent, there is a backflow or a regurgitation of the blood back. So kumbaga nagtatapo. So it also creates turbulence. And you will hear an abnormal sound also. Or you have shunting of blood out of a high pressure chamber or artery through an abnormal passage. So that also creates a sound, an abnormal sound. So the murmur should be described according to the intensity. So grade 1, when it is very faint and needs tuning in and focus of attention. So grade 2, it is faint but easily heard upon placing the stethoscope on the chest. Grade 3, it is moderately loud or intermediate. Grade 4, intermediate intensity murmur with a thrill. So may danahiya thrill. While grade 5, it is heard with the rim or edge of the stethoscope partly touching the skin. So nakaangat ng konti. Although nakatouch pa yan, nakaangat lang siya ng konti. Hindi nakadiin. So that's grade 5. So loud na siya, loud. Because you can hear the murmur with the rim or edge of the stethoscope lang. Samantala, the grade 6 is stethoscope is removed slightly from the contact with the chest wall, or it's a very loud na murmur that you can hear that even without a stethoscope. May aday ito mga sugad. So that's already graded as grade 6. So systolic murmurs. So you always start with your S1, then you listen for your S2. And then you locate where in the cardiac cycle this murmur occurs. Diba? Diba nasa rin kita? S1, systole na ito, start of your systole. Pag abot ito ni imo S2, that's already the end of systole, ma-start ng imo diastole. So between S1 and S2, if you hear a murmur between S1 and S2, systolic ito't iya timing, ha? So in cardiac auscultation, you have to remember that you need to focus first or identify the heart sounds. So yaw anay niyo i-identify ang ibang mga abnormal nga sounds. First, identify first and second heart sound. Is what I S2, or is it after your S2? So kung between S1 and S2, ano siya? Systolic, iti mo timing. So if it is after your second heart sound, that is diastolic in timing. So when you have systolic or hollow systolic murmur or pansystolic murmur, it always starts, the murmur always starts from S1. So nababatian mo hiya ay nga murmur from S1 to S2. Bali masing ka, labdab, di ba? May tatim mo pa, ano sound? Labdab. So pag sumaring nga niya, labsdab, that is systolic. Kasi after hanin mo, lab, nag-dab. Systolic, ito yung timing. Always locate first kung hainan imo first and second heart sound, or identify the first and the second heart sound. After the identification of the first and second heart sound, you now focus on the mga abnormal nga sounds and try to locate it where in the cardiac cycle this murmur occurs. Okay? So pag sumaring ka nga ning holosystolic, it occurs all throughout from S1 to S2. So kaya holosystolic. Pag sumaring nga early systolic murmur, so after S1, midway lang siya. Pag abot na tikadya MS2, waray ka na nababatian. You will not hear. Pag sinabing late systolic murmur, as in patients with mitral regurgitation, so you will hear the murmur at the mid hanimo S1, and then becoming louder as it approaches the second heart sound. So that's your late systolic murmur. So early systolic murmur in VSD, mababatian. While your pansystolic murmur can occur in patients with mitral regurgitation or insufficiency, tricuspid insufficiency, and patients with ventricular septal defect. So mitral regurgitation is produced by a retrograde flow from a high pressure area through some abnormal opening into an area of lower pressure. So, di ba, pag mitral regurgitation, you expect that during systole, this one is closed. But since kuan man hiya incompetent, there is backflow of blood into the left ventricle. So dapat unta diri ito. So you have retrograde flow from high pressure area to high pressure area pabalik nga. So that's why you see this characteristic murmur. So kung tricuspid regurgitation naman, dito siya. So you will hear that murmur at the left lower sternal border. And usually to identify whether it is mitral or tricuspid in origin, kasi parehas silang systolic, itira characteristic. Although one way is also the location of the murmur, but sometimes it kun you have a severe regurgitation ng mitral valve, pwede siyang may transmission to this area. So, di mo siya ma-identify, is this really a tricuspid regurgitation or is this mitral? So, you have to do certain maneuvers. So, you ask the patient to inspire. So, with inspiration, murmur of TR will increase. And you call that as your Carvalho sign. So, na-increase siya, ha? Murmur of TR would increase with inspiration. Whereas, if it's a murmur of MR, it will not. It's not affected by inspiration. So, VSD also could have systolic murmur. It is best appreciated at the lower end of the sternum. So, may xiphoid area. So, you can have short systolic murmur. This is in addition to the classical pansystolic regurgitant murmur that is seen in MR, TR, and VST. So, murmur here usually starts with the first heart sound and then suddenly stop during early systole. So, kaya ito, ganito. So, midway lang. At the start lang siya maririnig. So, this happens because as your ventricular volume becomes smaller after maximal ejection, the defect seals shut or seals off. So the murmur is no longer heard. So you can also have a late systolic murmur that is seen in mitral insufficiency. So the valve here is competent in early systole. But as ventricular volume decreases, the leaflets become incompetent. So the murmur begins which builds up in late systole, becoming maximal at the end of your second heart sound. So murmurs also can be heard in patients with mitral valve prolapse. So before it is called as Barlow's syndrome or the billowing mitral leaflets. So you will hear a click in mitral valve prolapse. So during systole, in mitral valve prolapse, normally you will have reduction of your left ventricular volume. So it reaches a critical point at which the mitral valve no longer coaptate. So if you have mitral valve prolapse, at this point, the click occurs and the murmur follows. So there are maneuvers that will alter this click syndrome. So like for example, when you squat, so squatting will increase your venous return, di ba? Kay na ano mo pressure. So it will increase your venous return. It will also increase the left ventricular volume. So nadakot mo left ventricle. So you will have a reduction in the myocardial contractility and an increase in the impedance of your left ventricular emptying. So the click will be delayed and the murmur will be relatively brief. So, kwan lahiya, short. With standing, so what happens when you stand? You will decrease the left ventricular volume by gravity, di ba? You decrease also the impedance to the left ventricular outflow. You decrease the venous return or augmentation of contractility. So you will have an earlier prolapse of the mitral valve. So you will hear the murmur becoming prominent and the click. So for mid-diastolic or mid-systolic ejection murmur, so it occurs in this part cardiac cycle. So mid-systolic murmur occur during period of ventricular ejection. So the onset of the murmur is separated from S1 by the period of isovolumetric contraction. So the murmur is crescendo-decrescendo in nature and will stop before the respective semilunar valve closure. So you have a diamond-shaped murmur. So you have a crescendo, so paloud and decrescendo. Do you have a class after? May daka mong klase after?
Wala po, Doc.
Waray? We can continue?
Pero walang Zoom.
Nawara na ansong?
Oh, hindi po, Doc. We have a class po, Doc, pero asynchronous, walang Zoom po mamaya.
What time?
Okay lang man, Doc, mag-extend.
We will finish na lang para next time libre na kamo. So you'll have time to study for the quiz. So for aortic stenosis, so the murmur is diamond shaped. So if you what's this? You use a phonogram. This would be the shape mo crescendo, decrescendo. So it occurs during systole. So it's an ejection murmur. Kasi di ba during systole dapat mo tricuspid. Sorry. Your aortic valve is open. Diba? Open ito hiya. Dapat open. But since it is stenotic, you create turbulence. Diba? One of the mechanism, a flow across a stenotic valve. So you create. So you will hear ejection murmurs of aortic stenosis. And this occurs during systole, systole. And the murmur radiates to the neck. Kasi ani nga area. So it radiates to the neck. So for coarctation of the aorta, you have to listen over the upper thoracic spine to hear the murmur if you are suspecting of coarctation of the aorta. So for pulmonic stenosis and atrial septal defect, so you can hear a wide splitting of the second heart sound. I already have explained this. And this may be due to the late closure of the pulmonic valve as occurs when you have right bundle branch pulmonic stenosis and ASD. So in atrial septal defect, the splitting is both wide and fixed. So with inspiration, ganyan siya. You have normal splitting of the second heart sound in the pulmonary area during normal in respiration. But when you have atrial septal defect, listening in the murmur area or in the pulmonary area, may splitting siya. Splitting. So it's not affected, huh? So you have fixed splitting. So splitting of the second heart sound. Okay, sorry. Can also occur when there is early closure of your aortic valve in cases of mitral regurgitation and VSD. So you can also have ejection murmurs due to pulmonic stenosis. So dito naman siya. Pulmonic stenosis. So for pulmonic stenosis, the degree of the murmur depends also on the severity of the stenosis. So in valvular stenosis with intact ventricular septum, your right ventricular systolic ejection becomes progressively longer with increasing obstruction to outflow. So the murmur becomes louder and longer. So it now envelopes your A2. And the B2 closure occurs after, occurs later after the splitting out, and it becomes now wider. Then your P2 now will be difficult to appreciate because the aortic closure, ito na dito. The A2 is lost in the murmur. So here, the A2 is lost already in the murmur. And P2 now becomes progressively fainter. So you will hear, so it's now become low pitch or soft. So as the pulmonary diastolic pressure drops to 0, isometric contraction will shorten to the point where the pulmonary ejection sound fuses with the first heart sound. So ito na mangyayari dito. Okay. So in severe pulmonic stenosis with concentric hypertrophy and decreasing right ventricular compliance and atrial filling pressures may appear. So for tetralogy of Fallot, you just listen at the pulmonary area, so you will appreciate the murmur. So for tetralogy of Fallot also, the murmur or intensity of the murmur depends on the severity of the lesion. So in TOF, with increasing obstruction of your pulmonic infundibular area, you will have more and more RV blood that is shunted across the silent VSD kasi may VSD siya. And less flow occurs across the obstructed outflow tract. Now with increasing obstruction, the murmur becomes shorter. So ito na. And the murmur becomes shorter, earlier, and fainter. The pulmonic valve closure sound is absent. So it becomes absent now with severe TOF. So in TOF, the larger aortic root receives almost all of the cardiac output from both the ventricular chamber and the aorta, the related aorta. So this dilatation is accompanied by an ejection sound, which maintains the characteristic of the aortic rather than the pulmonic ejection sound. So in mitral stenosis, you can hear an opening snap. So an opening snap is usually heard during diastole kasi opening na siya, diastole. So it's in the cardiac cycle, it's the opening of your atrioventricular valve. So in stenosis, so normally ganito yung opening. However, when you have mitral stenosis, the opening is obstructed, so hindi siya wide because the valve cusps are usually stiff, hardened na, nagdikit-dikit, thickened. So it will not open unlike in a normal valve like this one. So that because of a stiff valve, when it opens, it creates a sound. Pag open niya, snap na, snap ba? So you hear an opening snap. So if you locate the opening snap in your cardiac cycle, it occurs after hit mo S2. So opening snap of the mitral valve is high-pitched sound, and it is best heard between the apex and the left sternal border. It also radiates or may radiate to the pulmonic area. It is differentiated from pulmonic closure by listening to the three sounds of the aortic closure, pulmonic, and the opening sound, or the opening snap, which occurs in rapid succession during inspiration. So ganyan yan. A2, P2, tapos followed by your OS. Hindi dapat yung OS between the A2 and P2. A2 first, P2, and then your opening snap. So feeling murmurs of mitral stenosis. So when you have mild stenosis, the diastolic gradient across the valve is limited to two phases. Rapid ventricular filling in early diastole and pre-systole, and the rumble occurs during either or both of these periods. Kasi na-open naman ito't imo valve. When you have severe mitral stenosis, you will have a large gradient that exists across the valve during all of the diastolic filling period. So the longer the rumble, the more severe is the stenosis. So as your LA pressure becomes higher, the time from the aortic closure sound to the OS shortens. So when you have secondary pulmonary hypertension, this will result in a louder P2 sound and the splitting becomes narrow. So ito yun. So diastolic murmur. So you will have S1 tapos S2. So pag S2, you will have your A2, P2, and then your OS. And you have your diastolic murmur. So diastolic murmurs can also be seen in patients with aortic regurgitation or in patients with pulmonary regurgitation secondary to pulmonary hypertension. So the murmur starts almost simultaneously with your S2 as seen here. So simultaneous with S2 and imo murmur pag start niya. So the gradient between the aorta and the left ventricle is maximal almost instantaneously, and then slowly decreases. So the murmur also has a high pitch, low decrescendo character. So it diminishes also. The sound of the murmur diminishes. Kaya decrescendo. In valvular PR without pulmonary hypertension, this is manifested as a murmur which starts and has a rapid crescendo with a longer decrescendo. So lower pitch siya than the usual early diastolic blowing murmurs because the pressure gradient from the pulmonary artery to RV is very high or very slight lang. So for diastolic murmurs, so it usually begins with S2. So may decrescendo and blowing. So pag diastole, so it occurs after, It usually occurs after an imo S2. So diastolic semilunar valve murmurs as seen in aortic regurgitation. So you may ask your patient to sit up or lean forward for you to better appreciate the murmur. And press hard the diaphragm during held expiration. So you will hear the diastolic murmur. So the murmur usually in aortic regurgitation may radiate to the apex and to the shoulder, to the right shoulder or clavicle, so that you hear, you describe it as sash-like distribution, diba? Sash-like. It may even radiate to the neck also. Sash-like distribution. So a diastolic murmur of pulmonary regurgitation is usually heard at the second ICS, left parasternal border. For PDA, you can hear the murmur at the pulmonary area. So you need also to define what is a continuous murmur and a to and fro murmur, kasi dapat mo ito i-identify. Sometimes they are usually, the to and fro murmur are usually mistaken for a continuous murmur or vice versa. So for continuous murmur, these are an abnormal communication, or these are due to an abnormal communication between a high pressure system and a low pressure system that produces a large pressure gradient throughout your cardiac cycle. So it's called as diastolic murmurs or a continuous murmur. So the classical example here is your PDA. So at times, as I've said, it is confused with the to and fro murmur. A to and fro murmur is a combination of an ejection murmur, ejection murmur, and a murmur of semilunar valve incompetence. So the classical example is the murmur of your aortic stenosis and AI or aortic regurgitation. So you have continuous murmur that builds up to a crescendo around your S2. The to and fro murmur can be seen to have two components. So they have two components. You have mid-systolic ejection component and the decrescendo component, which disappears as it approaches your S2. Ito, nawawala. So you can also have functional or innocent murmurs. Usually they are described as soft, mid-systolic in time. It's not associated with cardiac abnormalities. They are best heard and recorded at the left lower sternal edge of the second or third left intercostal space. So they are often musical or grunting in quality. So the sources of these murmurs or functional murmurs or innocent murmurs are from the right ventricular outflow tract or from the root of the pulmonary artery due to an increase in the volume and velocity of ejection. So the intensity is magnified by physical activity, excitement, pregnancy, anemia, thyrotoxicosis, and fever. So about 15% of adults less than 40 years old will have functional or innocent murmurs. So you have functional murmur that is heard in the pulmonary area. So in patients with pulmonary valve stenosis of moderate severity, you can listen to the murmur at the pulmonary area also. So you can have cyclic vascular sounds that is heard in the neck, and this must be differentiated from your carotid bruit. So this could be from a radiation of murmurs from the base of the heart, or it could be due to high flow bruit over a toxic goiter or a venous hum. So if you have a murmur, you have to identify whether the murmur is functional, innocent, or it's an organic murmur. So you need to locate the area where you heard best the murmur, and I try to identify where the radiation of the murmur. So if you have already identified that it is functional, so what are the functional causes? Pwede siyang innocent murmur or from a venous hum. So if it's just a functional or an innocent murmur, then you proceed with looking at some physical signs. So if there are no abnormal physical signs, so there's no cardiac abnormality, no further work is needed. However, if it is organic, so what are some of the causes of your organic murmur? So pwede siyang holosystolic murmur, pwede siyang murmur from ASD or murmur from AS, and from other valvular lesions. So you can only identify that by trying to identify the location as well as radiation of the murmur. Try to determine the intensity and whether the murmur is affected by postural or respiratory changes or from other maneuvers. Try also to determine the duration and look for other physical signs. Now, if you have some abnormal physical signs that may lead you or give you some clues up to possible abnormalities, try to work up the patient. So do some ECGs, X-rays, or even do an echo. Or if there is a need for cardiac catheterization, proceed with cardiac catheterization so that you can proceed with your definitive management. So if it's congenital, valvular in origin, usually surgical manitut-ira definitive management. Either you replace the valve, you repair the valve, or you correct the congenital problem of the patient. So before I end this lecture, let me give you this saying from Durishis that auscultation requires continual practice to maintain finesse of the ear and exact perception of the heart sounds, just as the musician needs to practice agility and suppleness of the finger. So yes, this is my last slide. Thank you for listening. May daka mo question? So for my group this afternoon, ano ko lang ka mo, i-combine with the Friday group tomorrow because I have a meeting, ha? I don't know what time kami matatapos, so di ko gusto nga maano ka mabitin, maano tan pag kinulat ba. So we'll have it tomorrow together with the Friday group. Okay la iyo? Thursday group, okay la?
Yes, Doc.
So next meeting will be Tuesday, Tuesday. So waray na kita Tuesday. So our next meeting will be December, ano to? Ano yan na? 5, 6, 7, 8, 9, 12, 11 ba? Amot iyo quiz. Basta that you schedule. It'll be your quiz. So next meeting, waray na kita because we have finished today the murmurs already. Okay na? Sige, pag-attendance na. Kuan.
Tapos na po, Doc.
Tapos na? Okay,
Opo.
sige. Thank you.
Thank you, Doc.
Welcome.
Thank you, Doc.
Thank you, Doc.
You know,
Thank you, Doc.
Yeah.